Yes, so what we know with AD is we have a big problem because it is a very common disease, and almost all patients, in particular in early stages, have not been formally diagnosed. So there may be a recording of a memory complaint, but there's certainly not a proper evaluation of where exactly they are in the disease continuum, and definitely in very few cases, confirmation of the pathology with biomarkers. And so we have this backlog of prevalent cases that could be eligible for disease-modifying treatments, but we need to run them through a pretty complex diagnostic process. And that process typically starts with primary care because it is a population-level disease, and so we can't really start in specialty care with that. And what primary care docs tend to do with patients that come in with a memory complaint or in whom they suspect a memory issue is they do a brief cognitive assessment like the mini-mental or MoCA. And then if that were positive, they would usually go on and refer somebody to a dementia specialist, mostly neurologists. The very few primary care physicians do a full evaluation of the etiology of cognitive impairment themselves. That still is pretty rare. Some do, but not a lot. The problem with these referrals is that mini-mental MoCA have a relatively high false positive rate for MCI or mild dementia. It's about 75% specificity. So you are referring about a quarter of people that really don't have any cognitive impairment. They just scored poorly on the test. And because this is such a large population, you are sending lots of people who don't need to see a neurologist to neurology. And neurology not being a big specialty, that causes tremendous wait times. We have argued that already in 2017, when the first signals came along that aducanumab might work in Alzheimer's disease. And we kept looking into this issue over the years as the treatments became more and more a reality. And of course, nothing has changed. We still predict substantial wait times, and the anecdotal evidence from the early experience of lecanemab being available confirms that. I mean, if you look at the large memory centers, they all now report 6, 8, 12 months wait lists. And so what we predicted is actually unfortunately coming true. So the question now for us is, what can you do about it? Right? And one thing that would help is better triage for Alzheimer's disease in primary care, so that you refer with priority those who actually could be candidates for a disease-modifying treatment. And a logical way, which we had already analyzed a few years ago, would be those blood tests for Alzheimer's disease. So if you combine the information from a mini-mental that gives you reasonable evidence for cognitive impairment with the information from a blood test that gives you reasonable evidence for the presence of Alzheimer's disease as the underlying etiology, if you combine these two pieces of information, you can prioritize patients for referrals much more efficiently, and thereby you reduce the wait list and you get sort of the people who might be candidates for the treatment into appointments faster and then on treatment faster. And you can probably handle most of the ones who do not have Alzheimer's as the underlying etiology in primary care, because we can't really offer them any causal treatment. We can symptomatic treatment, lifestyle changes, adaptation to the disease, but for other etiologies we don't really have causal treatments. So that's the theory, and we tested the theory in a simulation model just because the treatments aren't around for long enough to test it, let alone the blood tests. They are not really routinely available, in particular not in primary care settings. So we developed a Markov model to see how the insertion of a blood test into the early diagnostic process in primary care affects wait times down the road. And we actually looked into two potential indications for that blood test. The first being a so-called rule-in-out test, where the test tells you, okay, if it's negative, it's pretty likely that you do not have Alzheimer's as the underlying etiology, but it doesn't confirm that you have it. It just says, no, you're not having it. If it's positive, you still need to confirm. And then we test the other alternative, that this would be a so-called rule-in test or a confirmatory test that would replace the traditional confirmatory tests such as CSF analysis or PET scans for amyloid. So we basically modeled these three assumptions, and we had to rely to a large degree on expert input because we don't really have these tests available in primary care, and we don't have a lot of primary care docs using them. So we had to use expert opinion as to how the test or availability or lack of availability would influence decision making. So based on their assumptions, we tested how the test will change decision making and then referral patterns, and then also speed to diagnoses in specialty settings.